Okay, good evening and welcome to the ACL themed webinar presented by the North East Musculoskeletal Society, also known as NEMS. For those of you that were unfamiliar with NEMS, we're a North East based not-for-profit organisation that aims to offer CPD for clinicians with an interest in musculoskeletal care. Particularly pleased to be venturing into our first digital CPD offering, which has attracted huge interest not just from the North East, the UK, but overseas, spanning 4 different continents. We'd particularly like to thank our sponsors, Ortho, for this evening, who've kindly allowed us to use their enhanced Zoom platform for this webinar to make it as interactive and enjoyable for you as possible. So before we get started, I just want to share with you a couple of housekeeping updates. Questions, there will be an option for you to post questions in the chat box. So you may have noticed that your mic is muted for everyone, but there is the option to use the chat box there to post questions. And those questions will be answered at the very end of both of the talks this evening. There will be some polls along the way, so do please engage with the polls where you'll be given a multiple choice answer. It's completely anonymous, so please do share your opinions and you will get to see the overall trend in response there. You will get a copy of the slides, so PDF copies will be shared with all the delegates registered. With those slides, you'll also get your certificates as well. And we are recording this webinar and we'll be posting on the NEMS YouTube page. So all that kind of information, the link to the YouTube page will be sent to the email which you registered with this webinar. Along with that, we'll also look for your feedback. This being our first venture into the digital world of CPD, we want to make sure it's as good as it can be, but also if there are things that we could potentially do better for future webinar type events, do let us know in the feedback survey that we send out to you. So I'm just going to stop sharing my screen for the moment. I'm going to introduce the first speaker, which is a consultant orthopedic surgeon, Mr. Sean O'Brien. Sean O'Brien works at the Sunderland hospitals in the northeast of England and also privately at the Spire and the Nuffield hospitals. A little bit of his background: he trained and qualified at Newcastle Medical School in 1990 and specialised in orthopaedic surgery thereafter. He completed his fellowship in Brisbane, focusing on knee injuries and sports injuries, and worked there with a number of professional teams over in Australia. He then went on to do another fellowship, this time in New York, specialising in more traumatic-based orthopaedic interventions. He's now kind of specialising predominantly in knees, soft tissue reconstructions, and it is widely published in the area of knee rehabilitation and reconstruction. And I can certainly offer my own personal testimonial for Lee's work after he reconstructed my own knee some 15 years ago, and it's still going strong. So I'd like to now hand over to Mr. Sean O'Brien.
We just need to, that should be it. Well, welcome everybody, and thank you for the opportunity to speak to you tonight about the anterior cruciate ligament, which is a subject that I've got a personal interest in. So, just before we start, disclaimers: I don't have any financial disclaimers. I don't work for Ortho, but again, I'd just like to thank them for sponsoring this webinar. So we're going to talk a little bit tonight about probably the most talked about 38mm in the world. There's more publications in the medical literature on the anterior cruciate ligament than just about anything else, possibly not coronavirus at the moment. I suspect that is taken over. But it generally means that there's still an awful lot of debate. In other words, all the answers around the anterior cruciate ligament, who we should operate on, who we shouldn't operate on, how we should rehabilitate the anterior cruciate ligament, etc., still haven't been answered. So we're going to go through a few learning points. We're going to talk a little bit about the anatomy, the epidemiology, the presentation of the injury, the initial assessment, which is very important, I think, from your perspective, surgical management, some of the outcomes and the future advances in surgical management. Now, I can rabbit on a little bit about this, and if I do, please feel free to interrupt and we'll shorten things out a little bit. As Nick just mentioned, I did my sports fellowship here in Brisbane, which is a fantastic city. We lived very close to this, which is the Story Bridge in the centre of town, so we had a fantastic year. And I worked for these two guys. The one on the left is Peter Myers, who's probably the big name in ACL reconstruction in Australia. The one on the right, there's always the sort of in many respects the more pastoral type person, Peter McMenamin. You may have heard of his nephew who went on to play first for Australia. I always tend to show this slide at the start of quite a few meetings. This is a slide that was taken from the operating theatre, and as you can see, it says 1:45, and this was one of Peter Myers' elective operating lists. It's 1:45 in the morning on it's Friday morning. We'd started this list at 7:30 on the Thursday morning, and the last patient was just going on the table now. So that's the sort of length of time that they tend to work in Australia. Following that, as Nick says, I was very fortunate to go to probably the most famous hospital for orthopedics in the world, the Hospital for Special Surgery in New York. Unfortunately, it was just after 9/11, so things were a little bit different there. But from my point of view, the fortunate thing was all the big names, all the famous people were staying put. And once you get into the place, you basically get a pass and you can go and see anybody operate and do whatever you want. So it's a great place to go and spend a little bit of time if you're going to do anything towards musculoskeletal disease. As I say, I now work at Sunderland, and I also work out of both the Spa and the Nuffield in Washington and Newcastle, respectively. So some of you probably don't recognize this character. He was one of Newcastle's most famous players, had a very, very short career of about 31 games. He's a guy called Tony Green, who back in 1974 injured his knee against Crystal Palace down in London and was stretchered off and never played football again. Unlike this guy, who most of you will know, and that's obviously Alan Shearer. And he went on, after rupturing his anterior cruciate ligament, to having it reconstructed, to having a glorious career both for Newcastle and for England. Now, things had changed dramatically between Tony Green's injury in 1974 and Shearer's injury in the early 1990s on the management and the rehabilitation of ACL reconstructions. And if any of you have ever had the opportunity to read Paul Ferris' his autobiography, The Boy on a Shed Roof, some of you may know Paul. He went on to become a physiotherapist after giving up his career as a professional footballer. He describes beautifully in his book rupturing his anterior cruciate ligament. Yet it was missed by a number of physiotherapists and orthopedic consultants, and his knee continued to give way, and eventually he ended his career having played only a handful of professional games and went on, as you know, to become a physiotherapist and later to become a barrister. It's a fascinating book, and it tells you exactly what happens when you snap your cruciate ligament. So a little bit about the anatomy. Its average length is 38 millimeters long. It's got a tensile load of about 2,100 newtons. It's made predominantly of collagen, of which 90% is type 1 and 10% is type 3. And there's about 5% elastin in it. It's got multiple fascicles. It is intra-articular, encased in a thin synovial sheath, but it's actually outside the synovial membrane of the knee, so it's extrasynovial. And it's got a very good blood supply from the middle and inferior genicular artery, hence when it ruptures, it bleeds quite a lot. As most of you are probably aware, it's made up of two main bundles. The anteromedial bundle is the larger of the two bundles, and it's tight in flexion, and it imparts predominantly antero-posterior stability. The posterolateral bundle is smaller, it's tight in extension, and that imparts rotational stability. The two bundles are characterized by their insertion on the tibia. So the AM bundle is in the front on the tibial footprint, and the PL bundle is behind it. The two bundles have got a stiffness of about 242 Newton meters. isometric. Its greatest strain is somewhere between 15 and 30 degrees, and it's viscoelastic. In other words, its deformation is rate dependent. If you stretch the cruciate ligament very slowly, it stretches. If you put a load on it very quickly, it ruptures. And you can see in this slide, the two bundles are tighter in different ranges of the movement cycle. Both of them being not the tightest, but the knee being the stiffest, around about the 30-degree mark. The fibers are orientated slightly differently. When the knee is in extension, the fibers tend to be parallel, and their insertion is more vertical. As the knee goes into flexion, the fibers cross over, and their insertion becomes more horizontal, and they rotate 90 degrees to each other as you pass from the flexion to the extension position. The function is primary stabilizer of anterior translation. This is supported by the dynamic secondary stabilizers of the meniscus, predominantly the medial, which is more fixed, and a little bit more mobile lateral side. They're also helped by the collateral ligaments, and especially helped by the ligamentous structures around the posterior corners, which are often missed in the diagnosis. They're also a secondary stabilizer to rotation. So a little bit about the epidemiology. On average, there's about 1 in 3,000 Americans rupture the anterior cruciate ligament. There's about 100 ACL ruptures annually, but this is going up all the time. When I did this slide a few years ago, 60 to 70,000 reconstructions in the States per year. I think at the moment that figure is more like double. It's 3 to 4 times greater in females who are playing the same sport. And there's definite increasing incidence of it, predominantly due to increased awareness of the diagnosis, and definitely an increased participation in sport, especially in the female population. There's also an increased expectation for return to sport from the patients that rupture the anterior cruciate ligament. So I think that's one of the reasons why the incidence and the numbers of reconstructions being performed per year are going up. So this is one of the poll questions, but sports involved tend to be sudden pivoting, plant cut maneuvering type sports. There's often an unforeseen event such as pre-injury contact, a sudden change in direction, and a loss of balance. Hence, it's a sport such as football in this country, rugby, handball, basketball, skiing, volleyball, and netball, which tends to cause the cruciate ligament to rupture. And if you could, can we put the first poll slide up? So for the hours participation, which sport is the most likely to lead to an ACL rupture? So I've given you 4 options here. Soccer, obviously, America, described as soccer. Handball, Eastern European, Northern European, very popular. Alpine skiing, or netball. So we're going to take that down. They submitted their answer. The answer is quite controversial in as much as there's no clear figure that says so. But the answer I've always been given is exactly what you've said, and it is netball. In other words, if there is a sport that is designed to rupture your cruciate ligament, it's netball. It's played predominantly by females. You've got to land on a fixed leg, and there's no traveling, and you're often off balance at the time of landing. So I think hours participation, certainly when I was working in Australia, where netball is absolutely huge, both in the male and the female population, it was the commonest mechanism of injury that we saw. The other one was touch rugby, because people have to divert and pivot to get round players rather than just charging straight through them as they do playing normal rugby. So a little bit about the mechanism of injury. It's predominantly an external rotation with a little bit of flexion and a valgus orientation to the knee. That is the commonest position that the knee is in when the cruciate snaps. It can also occur in internal rotation with flexion and varus, and you do see it occasionally in hyperflexion and hyperextension. I think most of you have probably seen the famous video of Michael Owen rupturing his anterior cruciate ligament. I can never get it to play on these presentations, so I'm not going to even try. But it's quite clear in that video. There's nobody around him. It's just the way he planted his foot and twisted his body when it snapped. Why do females tend to snap the cruciate ligament greater than men? Well, it's very multifactorial. There's both intrinsic and extrinsic factors. There's certainly a difference in the flexibility of the hamstrings. Their knees tend to be less stiff. They tend to have an increased foot pronation angle on landing. They've got a wider pelvis and more valgus orientation to their knee. The hormonal debate comes and goes depending on the sort of flavor of the month. There's definitely poorer neuromuscular control, and they do tend to have quadricep dominant knees as opposed to men. So, presentation of the knee joint. Do you want to, of an ACL rupture? Do you want to put up the second slide, please? Or the second poll question. So which is, oh, we changed that. I thought it was the third one. You can take that down or we'll put that up later. So presentation. The immediate presentations are the knee gives way and there's immediate swelling. And that's the thing, that's a real take-home message. That is somebody that comes to you in your clinic that says, I was playing sport, there's nobody around. Suddenly my knee gave way. I may have heard a pop, but there was immediate sudden swelling of that knee. That is a hemarthrosis, and that is significant. The amount of patients that go to A&E departments with that history and are still patted on the head and sent away and told that they've got a minor sprain of a ligament, it's just amazing despite all the educational events that we go to. So anybody that presents with immediate swelling of the knee is a hemarthrosis, and we'll go through the significance of that in a minute. There's often pain and often, if not always, an ability to play on. Sometimes people say that they played on for a little bit and then their knee gave way a second time. If they present later, they often present with a history of my knee keeps giving way, or my knees become painful, often because of secondary injuries. They have this recurrent joint effusion, it's never quite settling down. And they may have limited motion because of secondary injuries such as the stump of the ACL or a meniscal cartilage tear causing either true or potentially pseudo locking. If you asked how often these events happen, just think about the rules of thumb. This is what I always tell the registrars. Basically, if anybody asks you the percentage of things happening in ACLs, if you say 70%, you're fairly safe. In other words, 70% of ACL rupture in non-contact environment. 70% of people hear a pop. 70% are aged between 15 and 30 years of age. And this is the crux one. Frank Noyes, arthroscope, 2,500 consecutive hemarthroses, of which 72% had ACL ruptures. So if you see that acute, sudden hemarthrosis swelling of a knee joint, you've got 3 out of 4 chance of getting the diagnosis right that this is a ruptured anterior cruciate ligament. And you don't need all the other fancy investigations to make the diagnosis. People think you're very clever, but really you're just playing the odds that you've got 3 out of 4 chance of being right. So what happens inside the knee joint when you actually rupture the anterior cruciate ligament? Well, essentially there's an explosion goes on. The femur externally rotates and it falls off the back of the lateral tibia. And that's why you get the associated tear of the ACL, and primarily you get a lateral meniscal tear at the acute event. You get chondral damage in the center of the lateral femoral condyle, and as that rotatory movement continues, you may or may not get an associated medial collateral ligament stretch. The medial meniscal tears can occur at the time of acute presentation, but they tend to be more chronic, and that's certainly what was described in O'Donoghue's triad, the terrible triad of a torn ACL, a ruptured MCL, and a torn medial meniscus. That's what happened in the chronic knees that continuously give way. So the standard tests that we tend to do in the clinic are Lackerman's tests, where you try and slide the tibia forward on the femur with about 25 degrees of flexion. That's probably the most sensitive. The anterior draw test occurs at 90 degrees of flexion, where again you pull the tibia forward on the femur, and you often see physiotherapists doing that on the field, in football matches and rugby games. And then the pivot shift test, where you go from an extended position with the knee and valgus and internal rotation. And as you move up into flexion, the knee goes from subluxed into its normal anatomical position. Now, somebody with a very lax knee, you might be lucky enough to do that in clinic, but it's often a test that you've got to do in the operating theatre when somebody's under anaesthetic. And the reason the pivot shift test works is that with the snapped anterior cruciate ligament, as you internally rotate the tibia, the iliotibial band moves forward of the center of rotation of the knee joint. And then as you flex the knee up, the iliotibial band moves behind the center of rotation of the knee joint, and the knee is pulled back into its anatomical position by the ITB. So one of the things you've got to have a positive pivot shift is you've got to have an intact ITB, and you've got to have an intact medial collateral ligament to be able to pivot the knee round that position. So it goes from a sublux position of full extension to a anatomical position in flexion. So what investigations do we tend to get? I always like to get a plain X-ray, and that's mainly to rule out advanced osteoarthritis, because that is going to influence our surgical management or our non-operative management. It also rules out some other pathologies, such as have you missed a fracture, and it also shows you whether you've got a second lesion or not, which is a avulsion of the posterior capsule on the lateral side. And this was described by a guy back in the 1800s. And basically, if a second lesion is present, it's pathognomonic that an ACL rupture is present. Obviously, the investigation of choice for final diagnosis is an MRI scan. It's not essential, but I think it's very useful to look for other pathologies. And that gives you a better idea of the timing that you're going to need to do your surgery in. It tells you whether it's a multi-ligament injury. And if the diagnosis is in doubt, because diagnosis can be difficult clinically, it helps prove it. What you can see in an MRI scan is often the ruptures nearly always, not 100%, but nearly always off the femoral side, and the ACL stump falls down and sits in the intercondylar notch. So instead of it traversing up past Blumenstadt's line at the bottom of at the top of the femoral notch, it's more akin to lying flat on the tibia, and it's often attached to the PCL, giving a little bit of inherent stability to the knee joint. As you can see, the MRI scan also helps you see situations like this where there's multi-ligament injury, both ACL and PCL have gone, as well as medial collateral ligaments and probably some disruption in the posterolateral corner as well. So what's the initial management? The initial management of any ACL injury should be the same. It should be rest, ice, elevate. Get the swelling down, get pain under control, then get some gait retraining done, re-establishment of full range of movement, and rehabilitate the neuromuscular control. There was a vogue a few years ago for almost acute repair, especially people that went on skiing holidays to the Alps, and you would be taken down the mountain, sent to a clinic, and before you knew it, you'd had your ACL reconstructed. That's predominantly monetary driven, because nobody that comes back and repatriates back to the UK or other countries is likely to go back to Innsbruck or Geneva or wherever it is to have their ACLs reconstructed. So they tended to do them early because that was when they had the captive audience. Do all ACLs need reconstructed? Well, the simple answer to that has got to be no. Nobody needs an operation. Nobody's ever going to die of an ACL rupture. And therefore, you've always got to give them the option of non-operative management, or at least a trial of non-operative management. And there's lots of papers over the years that have proven that you can cope without an anterior cruciate ligament. Guillaume, back in 1983, had 14 of his 24 patients return to their pre-injury level of sport. Joel had a 28 patient cohort, 3 as a follow-up, and again 11 out of 15 got 11 to 15 had got to return to their contact sport, and 6 out of 9 to non-contact sport. but instability was an exclusion of this study. So in other words, anybody that presented with instability symptoms was taken out of the study and operated on. The non-operative treatment of ruptures of ACLs in middle-aged patients, again, Shiokoti showed that he got very good results in patients that had quite significant laxity of the knee, 97% grade 2 to 3 Lachman's test, and 83% positive pivot shift test, but 83% of them were satisfied with their non-operative management. This is probably one of the most famous studies done to look at who succeeds without reconstructive surgery. We started in Delaware and then taken on by the Oslo group, and they had 300 highly active patients enrolled, of which just short of half of them decided to choose initial non-operative management. However, after the non-operative group, 37% then went on to have a late reconstruction within 2 years, and 11% had poor functional results. 52% good outcome comparable function to the uninjured group. And basically that gives you a similar sort of picture to the famous rule of threes that was described by Frank Noyes in his 2 papers, The Symptomatic Anterior Cruciate Ligament Deficient Knee. Basically what Noyes said was that with non-operative, after an ACL rupture, with rehabilitation, a third will get back to their sporting activity, a third are likely to change their lifestyle, and a third will need reconstruction. I think really what happens is the ones that get back to sport, some get later giving way and end up having surgery, and the ones that change their lifestyle are the ones that really just give up sport altogether. So what happens if we leave an anterior cruciate ligament? Well, unfortunately, the more episodes of giving way that occurs, the more likely you are to damage your meniscal cartilage and damage the chondral structures. And Greg Keane in Australia came up with a recommendation that patients that have got chronic ACL insufficiency should have the ACL reconstructed early so that you can repair any meniscal cartilage tears that may be present. Roughly, meniscal cartilage tears in an unstable knee, and that's what you've got to take home, somebody that after rehabilitation has still got a knee that's giving way, are going to occur at about 10% per year. Roughly 40% at 1 year, 60% 5 years. So by 10 years, with an chronically unstable knee joint, you'll have an 80% chance of a meniscal cartilage tear. And the effects of time course on the correlation of meniscal and cartilage injuries shows that injuries 2 years old, the meniscal damage is 18-fold, there's meniscal cartilage damage and an 18-fold increase in cartilage damage. Sam Church, who works down in London, did a great study looking at the timing and the incidence of meniscal cartilage and the development of degenerative tears. Basically, he concluded that ACL reconstruction should be carried out before 12 months in an unstable knee to reduce the risk of meniscal cartilage tears and degenerative changes. And again, Donald Shelbourne showed that if you've got no meniscal pathology at the time of surgery, you can get a very good outcome. But if you leave it till you've damaged the lateral, the medial, or both meniscal cartilages, the success rate and your outcomes functionally reduce. So the one thing we want to avoid is an x-ray like this. This is a patient that actually came to see me in clinic only a couple of weeks ago, just before the lockdown, and he'd had a chronic unstable knee for many, many years, never been operated on, and you can see he's got a grossly arthritic joint at the age of 56. So we're now going to move on to ACL reconstruction, actually the surgery itself. So you can have a series of indications. There's the absolute indications, such as part of a multi-ligament instability. Professional athletes, extremely difficult to persuade them to go for non-operative management, and essentially your active casual athlete. In my practice, anybody that's got functional instability, in other words, a knee that's giving way or a knee that's likely to give way because of their choice of either occupation or sporting endeavors, I tend to offer them reconstructive surgery. There's got to be some relative contraindications. Obviously, underlying osteoarthritis, the ACL reconstructions can advance that. We know that people of advancing age may just want to change their lifestyle, and younger people that have got open growth plates, you certainly go for a period of rehabilitation initially in children before offering them surgery. If you've got hyperlaxity, marked malalignment, or poor neuromuscular balance, you've got to be very wary of the outcome of surgical intervention, and you want to think twice about doing an ACL reconstruction on somebody that's got hyperlaxity, and especially somebody that's malaligned. You need to correct that first. It's about timing. Certainly you don't want to do it straight away. The acute phase is recommended to be anytime within 6 weeks. In the health service and even really in private practice, you're lucky if you get somebody in within 6 weeks. But you want it when the knee has got little or no effusion. You've got a good range of movement. You want ideally to have no extension deficit. Often there's a locked knee and you can't get the knee fully straight. You don't really want to have the knee that's tender to touch, and it should be calm and quiet, and ideally relatively comfortably before surgery. Lars Engebretsen used the Norwegian knee ligament registry, which is probably the longest running knee ligament registry in the world, to look at the timing of ACL surgery and the risk of cartilage and meniscal damage. And again, every month that elapsed from injury date to surgery date, the risk of cartilage lesions were nearly twice as likely, and meniscal cartilage tears and vice versa. So the aims of surgery are to replace the damaged anterior cruciate ligament with an anatomically accurate substitute of a similar and stronger biological nature. So it sounds pretty straightforward, pretty simple. I like to think that I wish it was pretty straightforward and pretty simple, but unfortunately, it's an operation that is prone to complications. It's technically quite difficult to do, and it's definitely shown the more you do of these, the slicker and smoother and better results that you tend to have. So what sort of grafts available? You've got your autografts, so the classic bone patella tendon graft. Probably the most popular graft these days in the UK is 4-strand hamstring graft. And then there's the newer grafts coming, increasing popularity of quadriceps tendon. In America, allografts are still very, very popular. 46% of primary ACL reconstructions in the States are still allograft, despite terrible re-rupture rates. So they tend to use bone patella tendon or Achilles tendon allografts. And there is the synthetic grafts. We've been round and round the houses with those, and certainly I wouldn't recommend those for primary ACL reconstruction. You've got to think what you want of it. Think about the graft's strength, how you're going to fix it, what's the healing properties of the graft, what are the donor site morbidities and rehabilitation rate. If you've got, say, somebody that's a floor, you don't necessarily want to be doing a bone patella tendon graft from the front of their knee, as they're likely to get chronic anterior knee pain if you did that. Each graft has got its own tensile load. The double strand hamstring graft is probably the strongest single type of graft that you can get. But you always need to have a fallback. There's no point in just being proficient in one. You've got to be able to harvest a hamstring, be able to harvest a bone patella tendon graft, and even a quadriceps graft, because disasters always happen during surgery. The hamstrings might not be good enough, and you've got to move straight away to a BTB graft. So my ACL reconstructions always start with a pre-reconstruction arthroscopy, basically looking to see if there's any associated articular cartilage damage and any meniscal cartilage repairs that need to be repaired at the same time as surgery. You want to confirm your diagnosis, and what you're looking for is basically an explosion inside the intercondylar notch, or what is referred to as an empty lateral wall sign. I then tend to harvest the graft. My primary graft of choice is a quadruple hamstring graft. I don't look after that many professional sportsmen, and certainly in people's practice, who are predominantly high-class sportsmen. I think the graft of choice is moving away from hamstrings and moving back towards bone patella tendon grafts. Basically, we then do an arthroscopy, we clean the intercondylar notch, and we start drilling the two tunnels. The tunnel placement is crucial to the success rate of an anterior cruciate ligament. There's different ways that you can drill the tunnels. Transtibial was a very popular choice once upon a time, but most people have moved towards using an anteromedial portal to drill the femoral tunnel. There was a vogue a few years ago of bringing the tunnel on the femur further forward, more into the anatomical footprint of the ACL. There's a vogue for all inside techniques, and we'll briefly talk about double bundle later. And more people are using computer guided assistance to get the tunnel position right, or fluoroscopic guided assistance. The transtibial tunnel was extremely popular once upon a time, but it tended to lead to an extremely vertical graft. As a result of that, the graft gave little, if any, rotatory stability. It was very, very good for giving antero-posterior stability, but very little rotatory stability. You can see just on this diagram the difference between a vertical graft and the more horizontal graft going at the 10 o'clock, 2 o'clock position on the graft face, which I think most people aim for these days. Certainly my technique is using an anteromedial portal, and it always has been. And this gives you a great view of the femoral footprint, both the AM and the PL footprint, and the lateral intercondylar ridges and the lateral bifurcate ridge. If you use an accessory medial portal and flip your cameras and look from the lateral to the medial side, you can see directly up the medial tunnel. When we were doing anatomic reconstructions a few years ago, we were definitely moving the graft further forward and further down on the footprint on the femur. However, that did end up causing quite a few disasters. And I think most people now have moved from using sort of Herzl's grid technique of going for the center of the anatomical footprint slightly further back into the AM footprint. There was also a vogue of using a ruler technique where you measured the length of the femoral condyle and came about a third of the way along to hit the center of the anatomical footprint. What you do need to see at the time of surgery is you need to see the back of the notch. If you can't see the back of the notch, you can't judge where that femoral tunnel needs to be. My ideal placement is on the 2 o'clock or the 10 o'clock position, depending on whether it's the right or the left knee. And then I come forward about 5-6 millimeters, make a starting hole, and drill my hole depending on graft size at that point. Then flip the portals to check the position of the tunnels, measure the tunnel length and over drill it with the size drill you need from the AM portal. Then drill your tibial tunnel, and this really wants to be the center of that tibial footprint, so it comes in parallel to Blumenstadt's line. I reference it from the anterior horn of the lateral meniscus and the medial tibial spine. If you draw a line between those two and just come out just on the posterior aspect of the anterior horn of the lateral meniscus, you'll be about right for your tibial footprint. And you then pull the graft through the knee and secure it with whatever method of fixation that you want. And my preferred method of fixation on the femur is a fixed loop endo button, and this is a fixed loop endo button going up. You're then going to put the knee through a range of movements, and you're going to tension it depending on where you've put that femoral that femoral footprint. I normally tension my knees around about 30 degrees, and then I fix it on the tibial side with an interference screw. There's numerous different ways of fixing the graft. It's basically personal choice. There's lots of different inside the joints, both interference on both the tibia and on the femur, and outside the joint, either the cross bolt, the endo button, which is becoming the most popular form of femoral fixation, screws and washers, and even staples. And again, every type of fixation has got a different tensile load to failure. You see cross pins are very, very strong, as are endo buttons, but they're at the right of the screen, I think, covered by the pictures. Basically though, during surgery, if you do enough of them, you're going to have disasters, and you've got to be able to cope with this. And this is what can happen if you're doing bone patella tendon graft. It's very rare, but it's, you know, it does happen even in the best of hands that you can have a patella fracture. Once the surgery is done, the next phase is obviously post-operative rehabilitation. And I'm not going to cover this at all because obviously Lee's going to cover this, I should imagine, in quite significant detail. So what are the results of ACL reconstruction? Leo Pinchowski's probably done more ACL reconstructions as an individual than anybody else in the world. He normally stands up in meetings and starts talking about his 8,000 ACL reconstructions. And when he started, he did bone patella tendon grafts predominantly, of which he had very successful initial grafts. But he was always worried that the fact that 24–25% of them went on to get degenerative change, no matter whether they had meniscal cartilage pathology at the start or not. So he then changed to using hamstring grafts, and again, very good survival rate of 83%. A lot get back to strenuous activity, but there is a definite less or a lower rate of osteoarthritis in a hamstring graft than in a bone patella tendon graft. And again, 15 years outcome following his bone patella tendons, 51% now had osteoarthritis. 70% had anterior knee pain. Very small graft failure rate considering it's 50 years out, but 24% had a contralateral ACL rupture. Agaletti, again, had a 10% graft failure rate, but 80% returned to pivoting sport. Back, again, 89% good or excellent HS, hospital special surgery scores. Segal, good results, 98% full knee movement, 83% return to sport, but it doesn't say what sort of function they return to, but 92% of people rated their knee as good or near normal. Julian Feller, again from Australia, looked at a systematic review and meta-analysis of the state of play, and this was sort of almost 6,000 patients, of which 82% returned to sport of some level, 63% returned to their pre-injury level of sport, 44% to competitive sport. But 85–90% of people reported normal or near normal knee function. So the results are very good, but nowhere near as many people get back to their pre-injury level of sport as we sometimes think. And basically, Feller concluded following this patients that low rate of return to sport might be a little bit more to do with psychological factors as much as you know, the sort of surgery and the quality of the reconstruction itself. And certainly when you look at somebody like Michael Owen, it was definitely a psychological element in why he didn't manage to get back to being the player after he ruptured his anterior cruciate ligament that he was beforehand. Again, in younger people, there's a significant risk of rupturing either the anterior cruciate ligament graft or the ACL on the opposite side. And this goes up to a potential 21% of somebody under the age of 25 that's had one cruciate ligament, 21% risk that they'll get another cruciate ligament rupture. Can you speed it up? The French FAST study showed that after an excellent 5-phase rehabilitation program, an assessment both isokinetically and psychologically, at 6 months, there was still a general unsatisfactory state of the knee joint and an increased risk of recurrent tear. So it's a slow process. It's a really difficult buy-in for somebody that has an ACL reconstruction. It's going to take them 9 months to a year to get back to full sport and full activity. So a little bit about why they fail. There's no doubt early aggressive physical exercise can be a contributing reason for failure, but I think the patient is something that the surgeon likes to blame. When it goes wrong, the surgeon always likes to look at the patient first and say that it's their fault, they were doing too much, too soon, too quickly, when if you're being honest about it, a lot of the time it's on the surgeon's side that the errors are being made. Those failures can be because of intrinsic within the patient or extrinsic surgical. The graft can be poor, placement can be poor, fixation can be poor. Associated injuries lead to poor outcomes, meniscal and chondral damage. And if they don't go through a good rehab program, nobody's going to get very good results. Also, if you've got a hyperlax patient, you may not have assessed that properly. You may not have assessed the alignment properly and corrected that before you went on for surgery. Does graft size matter? It definitely does. I think we're now very aware that really if you're using a hamstring graft, you want a graft of about 8.5 millimeters or greater, and then your revision rate is coming down. If your graft is only up to 8 millimeters, you've got a 6.5% chance. And if it's less than 7.5 millimeters, you've got a 13.6% chance. Really within 1 year, these were 14% follow-up of a re-rupture. Femoral tunnel placement, as we've gone through before, is crucial to the outcome. If it's too far forward, as was the case in the anteromedial portal or the anatomic portal, the anatomical reconstructions are tended to fail in flexion. If it's too far back, you tend to blow out the back wall and not get particularly good fixation. And if it's too vertical, it fails to control rotation. And again, Adrian Wilson, who was a great advocate at one stage of the anatomical single bundle ACL, has gone back to using the anteromedial portal and the placement we were both taught by Peter Myers in Australia, because of there was a higher rate of re-rupture, early re-rupture in the anatomically placed ACL. In the tibia, these are the ones that restrict range of movement. If it's too far forward, the tibial footprint, you get notch impingement and you're unable to extend. And if it's too far backwards, you get PCL impingement and you're unable to flex. So why does the fixation fail? Often inadequate size of the screw. You haven't completely encased the whole of the interference of the tunnel with the interference screw. You've blown out the posterior wall. The bone's too soft to take a good screw fixation. You failed to toggle the endo button and you haven't appreciated that. You've missed the tunnels altogether. I've seen screws just lying free inside the knee joint and people have come for revision. And you've had intraoperative graft rupture. This can occur especially when you're starting to put the interference screw in a bone patella tendon graft on the femoral side. The screw can tear the graft. And that's when you need to be able to go back to a secondary graft if you need to. So we're coming to the end. I just want to briefly talk about future trends and how we can maybe improve some of these results. Definitely there is another look, another focus going on in non-operative management, or at least a trial of non-operative management. And David Beard in Oxford is running a multi-center national study called the ACL SNAP trial, looking at the effectiveness of strategies for non-acute anterior cruciate ligament reconstruction, rehab versus reconstruction. The results of that are not available yet because it's only been going a few years. And certainly people like Freddie Few in Philadelphia is always trying to push the boundaries. If you go and listen to him, everything that he did 2 years ago seems to have not worked, and he's looking for a different perspective on it. He's looking for a better technique, how he can improve the situation, how he can improve it for each individual person. He's an absolute minefield of ideas on how to improve the situation. And one of his great ideas at one stage was moving to the double bundle technique, which was taken on by a lot of people, especially in the professional sports field, and especially in the Far East. And most of the papers on double bundles come from the Far East. There's a saying among most of us that do a lot of ACL reconstructions is double bundle, double trouble, because basically it has fallen a lot out of popularity because of the complication rate. And even though it gave better lab results of rotational stability, it was never proven in functional outcome in clinical papers to have a significantly superior outcome over a well done single bundle. ACL repair, in other words, leaving the stump and just trying to repair it, has definitely been looked at again in the last few years. Arthrex's internal brace has become certainly very popular among a group of surgeons who believe that if you get the damaged knee early enough, you allow it to settle down for a few weeks, and there's a good enough stump that you can repair it and you can augment that stump with a internal brace. De Felici, again working in the hospital special surgery in New York, is a great advocate of this, and he looked at 56 consecutive patients that he did primary repairs on. The last 27, he added the additional internal brace, and he showed that the failure rate without the brace was almost halved when using the brace. So he believes that there is definitely a role for internal bracing, but I don't think we're quite there yet on who we know on who to use it upon. Martha Murray's group in Boston have come up with this idea called the BEAR implant, which is bridge enhanced ACL replacement or repair. Basically, there is a matrix placed at the proximal aspect to fill the gap between the ruptured anterior cruciate ligament and the top of the notch, and then this matrix is injected with blood. And you can see this paper only came out this month. I only found this today, and that's the early 2-year results of the BEAR technique. And it's a great study because the patient is completely blinded to whether they've had a standard anterior cruciate ligament reconstruction or whether they've had a BEAR. Quite a few of the patients dropped out of the study and did convert from the BEAR to their ACL. Obviously, they're going to know that they've had that because they've had a second surgery. And there was a revision rate. But again, in the younger patient, maybe the skeletally immature patient, it's something that's definitely going to be looked at in more detail in years to come. And it's a great study, the fact that it's actually a randomized controlled trial. There's no doubt about it that plasma-rich proteins and stem cells are vogue in a lot of private clinics, and they're certainly vogue in the press, and there's definitely a role for them. I would have a word of caution, is that there's numerous different ways of preparing plasma-rich protein. You tend to find that people buy in one type of centrifuge, therefore they're preparing exactly the same product every time. And that for every individual injury around the knee, you really want to be using a different form of PRP, a different form of stem cell therapy that is particularly targeted at the understanding of the injury that you're trying to treat, the environment of that treatment, and what you hope the biological therapy is going to deliver. And if you look at Robert Leprade in this year's BJJ 360, gave a good overview of biologicals in orthopedics, not just for ACL reconstruction, but for muscle tears and tendinitis and such forth. Well, we've got to know that it is safe. It certainly does favor donor site healing and bone patella tendon grafts, and it does appear to speed up graft maturation. However, again, like a lot of the changes that have taken place, it did not at the moment provide superior clinical or functional outcomes. We have definitely in the last few years though started to reinvent the wheel. These two guys, McIntosh and David Dandy, were ridiculed really in the early 1990s when everybody like myself came back from Australia and started using single-stranded hamstring techniques arthroscopically. And their technique of bone patella tendon graft with an extra-articular lateral tenodesis was poo-pooed and said that we didn't need it. Then in 2013, it came out in basically all the national press really before anybody read the paper in the Journal of Anatomy that Bellemans group in Belgium had found a new ligament inside the knee joint. Well, Sigond, the man that described the Sigond fracture, first postulated that this ligament was present in 1879. There's lots of debate whether it's a ligament or just a fascial condensation, and there's lots and lots of debate where does it anatomically attach. There's been lots of cadaveric studies looking at the anterolateral ligament reconstruction versus a semi-anatomical extra-articular tenodesis. i.e. a Lemaire or a Macintosh. And again, both techniques have been shown to add definitely to the rotational stability of the knee joint. Andy Williams and Andrew Amos have done a lot of work at Imperial College on this, and I know that Andy Williams has definitely moved away from a single-stranded hamstring technique, which we were both taught by Peter Myers, moving definitely towards a bone patella tendon and an associated extra-articular tenodesis, and he's high-class professional sportsman, which is most of his practice. And certainly I, myself, in certain patients have moved to using this technique. It is more invasive. It does involve a larger cut down the outside, but I think it definitely adds to that rotatory stability that you don't get with purely single-stranded hamstrings all the time. But basically, in patients that I get that have now got hyperlaxity, a marked grade 4 pivot, in other words, when the pivot catches just before you go into the reduction point, if they're high-level sportsmen or they're a revision anterior cruciate ligament, I tend to use now a bone patella tendon and a extra-articular tenodesis. So if there's any take-home messages from this talk, ACL ruptures are common. Not everybody needs a reconstruction, but don't leave a functionally unstable knee joint. Choose your reconstruction technique and do it well using a good graft in appropriate positions. Rehab is the key to a good outcome, and always think about adding an lateral tenodesis if you're worried about the stability. So I know I've gone on a little bit, but that's the end there.
Great. Thank you, Mr. O'Brien, for your surgical perspective there. Thank you, Mr. O'Brien, for your insight into the surgical perspective and management of the ACLs there. We have had a few questions come through on the chat box down below, so we will, as mentioned earlier, park those for the moment and revisit as many as we can at the end of the final presentation. So thanks again, Mr. O'Brien. I'd now like to introduce the next lecturer, which is Dr. Lee Herrington. So Lee is a senior lecturer and program leader on the MSc Sport and Rehab course at Salford University. He's also the technical lead physio with the English Institute of Sport and covers the lower limb rehab side of things for both the Olympic and the Paralympic squads. In addition to his clinical roles here, he also offers extensive consultancy services to both professional football and rugby squads in the UK. Academically, Lee has published over 200 peer-reviewed articles relating primarily to anterior knee pain and ACL rehabilitation. And he is also the editor-in-chief of the Physical Therapy in Sport journal. So I'd like to now hand across to Dr. Lee Herrington, that will give us his experience and insight into all things rehab. So over to you, Lee.
Thanks, Nick. Thanks to Ossa for sharing the platform. Thanks to Sean for his really interesting talk. So I'm going to try and talk through some of the edited highlights of post-operative and pre-operative ACL management. So when we're going here, what we really are looking at is, well, the first thing is, can you prevent an ACL injury in the first place? Well, in order to do that, we probably need to understand the risk factors and so have a clear understanding of modifiable and non-modifiable risk factors. So we'll discuss that. And then in terms of if we're going to then rehabilitate an ACL reconstructed knee, we probably need to understand why things go wrong or what probably predicts a poor outcome, because this will then give us what are almost certainly the weak areas within our rehabilitation. So what we can do then is we can start to fill in those gaps and get going with that. So if we look at ACL injury, we have non-modifiable and modifiable factors which could create that injury. And our non-modifiable can be the intrinsic knee anatomy, gender, and some degree of medial joint laxity. And our modifiable very much are neuromuscular control or optimal or suboptimal movement and the environment. So if if we break that down and we look at non-modifiable, and it's very important to understand the non-modifiables, because they're actually where most of the science is as to why people get ACL injuries. So if we look at a notch-width ratio, which is identified from the diagram, if your notch width ratio is less than 26% or 0.26, you are highly likely to get an ACL injury if you do some other things we'll talk about in a second. If you've got a reduced ACL volume, so number D on the MRI scan, you are again far more likely to get an ACL injury, and obviously reduced volume is more common in adolescents and females. If you have a patella tendon tibial spine angle, which is greater than 27-ish degrees, again, you're more likely to get an ACL injury, because this is likely to put an anterior displacement or traction on the ACL. And then we have what has been grandly titled ACL impingement, which is, if we look down at the view of the leg to your right, what you will see is the ACL being impinged within the notch as we go into this valgus rotated position, commonly cited as the cause of injuries. And then if we take into account females are more likely to get ACLs relatively than males, an interesting thing was found, which was ACL volume increases in these female players over the season. So that would crowd the notch and possibly increase the risk of impingement. So again, possibly the combination of two things increasing the risk, along with a narrow notch width. If we then are going to impinge our ACL, we are likely to have accumulated microtrauma, which then could lead to breakdown. And a much underreported or under-talked about study by Lips, where he took cadaveric knees and he applied a 3 times body weight force, which is about the equivalent of landing from a 30-centimeter box. And he took these cadaveric knees and he did 50 repetitions of this 3 times body weight load, taking them into this valgus position. And what he found was you started to see microfailure of your ACL in under 50 repetitions. So if we go back to Sean's netball example, if you're a centre court player in netball, you're probably going to land on that leg 50 times in a match. So you're probably, if you're doing that with the unfortunate valgus rotated position, likely to be creating microtrauma in your ACL, which could then go on to create problems if you don't give that sufficient time to recover. Another non-modifiable factor, as we've said, is the female question. And again, females are at higher risk than males post-puberty, which suggests a hormonal effect. And we know that this risk appears to be increased in the pre-ovulatory phase, so around sort of day 7, 8 through to day 14. And we know that if we modify the menstrual cycle and shrink down that pre-ovulatory phase by using things such as oral contraceptives, we can change relative risk. Now, that is not to say this is the sole factor, and it is likely to be an interaction with the anatomical features we've talked about previously and some others we're going to talk about. So in terms of modifiable, probably the one people don't appreciate is the environment. COF is coefficient of friction. If we have a high coefficient of friction between our shoe and the ground, we are likely to, when we land or change direction, increase the chances of us having a shallow knee flexion angle and doing a greater knee abduction moment, so putting greater stress on our ACL. So high friction seems to be a potential mechanism. And we know wooden floors, dry grounds are associated more with ACL injury. And we know artificial turf, again, another high friction environment, is associated more with ACL injury. And this is probably based around the shoe surface interface and generating rotary traction between the surface and the shoe. And this is going to very much vary across shoe type and surface. So one of our considerations to avoid ACL injury is likely to be our consideration of shoe and surface. And then we get to neuromuscular control. Everybody talks about neuromuscular control, and if we can just only control knee valgus, then we can prevent ACL injuries. It's probably not that simple. There's lots of programs which have done this and improved the landing quality of individuals. The problem is most of these studies were done in the labs, and their outcomes were biomechanical measures, not necessarily a reduction in ACL rates. It was assumed that by improving movement we would reduce the rate, but it wasn't shown. In the studies where they did reduce the rate of injury, these were generally all done on adolescent females. And again, the adolescent female group, and this is, I work a lot with female sport, so I think I can probably say this, adolescent females generally, though highly talented, aren't the most athletic. And so generally, any training program could improve physical qualities, which might be able to reduce risk. And so the thing we've got to consider is we've got to stop concentrating on the knee valgus angle and think a little bit more about the forces. And the force we are considering is the knee abduction moment. And this is influenced by the knee valgus angle, but the moment is also influenced by foot placement, hip position, and trunk position. So by merely concentrating on having a smaller angle at the knee, we could be missing a lot of other things which are increasing knee moment. So that's part of the complexity. And the second thing is just stiffening the knee, i.e. landing with a slightly straighter knee so it doesn't go into valgus, is likely to create problems, because an ACL strain, as Sean talked about, is likely to be this combination between knee extension and abduction load. So there's a knee extension force or a knee extension moment plus an abduction moment, which breaks the ACL. And the other thing about these neuromuscular control programs is it is currently unclear if these training programs actually transfer consistently into sport performance. And we're going to talk about that very briefly now. So if we look at poor movement or poor movement control and try and understand why. So the first why is likely to be we lack strength. We could lack strength in our quadriceps, so we can't control the knee extension load. We could lack strength in our hip abductors, so we can't control the valgus. We could have an absence of range of movement, especially our ankle. If we lack ankle dorsiflexion range, we are more likely to go into valgus as a compensation for the lack of that range. If we have poor joint position sense or an inability to know where our limb is in space, we are more likely to go into a valgus position and put valgus or abduction load through the knee. Probably one of the most important things is if we don't understand the question, we are highly unlikely to give a correct answer. So what we've actually found with a lot of research is people don't understand the question you're asking them when you give them a movement task. And when you start to explain the answer, i.e. you give some coaching cues, you facilitate, you give verbal or visual feedback, these people improve their performance quite dramatically and quite quickly. So all of the above factors can't be the problem. It's probably simply a processing issue. And then what we have is the majority of these training programs, so we're trying to teach people using verbal and visual feedback to land correctly, are what we would call a closed skill. They occur in a very controlled environment, and that's great doing an optimal performance in a controlled environment, but unfortunately it doesn't resemble the real world. In the real world, where things are what we call open and they're random and not controlled, we have context. So the context can be related to the nature of the sport, so the sports related movements. So landing well doesn't mimic pressing in football, where you're trying to reach out with one leg and prevent a player from going past you. It doesn't mimic a single leg landing in netball, where you're catching a ball over your shoulder while looking in the other direction to then feed the ball rapidly to your next player. It doesn't involve the decision making which is involved in sports, so having to dissociate your head movement to look for opposition whilst at the same time deciding what your next move is. or whilst at the same time trying to react to an opposition player. So we suddenly get very, very complex. And now we've got psychology, which overlays all this. Have we just been harangued by the coach? Have we just been harangued by the crowd? Have we just made a mistake? All these things will affect our decision making and our performance. And on top of that, we also can be fatigued. And there's been a lot of talk on, especially social media, about fatigue not being related to ACL injury. That is because they are merely looking at assuming fatigue is time into the game. Anybody who's played sport knows that you can be blowing like mad in the first 5 minutes and perfectly calm in the last 20. And so that alone cannot be the judge. It very much, your fatigue is related to the previous activities you have done, not just the length of time into the game. So we have all these things. So then what we have, if we want to prevent ACL, and also if we want to move forward and think how we are going to rehabilitate these patients well, is eventually we have to develop a bandwidth around a contextual performance. It cannot just be about landing well in a gym, in a very closed environment where they can really think about it and concentrate. Eventually, they've got to do this in full combat in sport. So hold that thought as to why things go wrong. If we look at then moving on to the ACLR itself, first thing probably to do is understand people's motivation to have an ACL. Well, they choose to have an ACL invariably because they want to improve their function. They have either actual or perceived giving way. They believe that the ACL will allow them to go back to sport, and they believe that the ACL will reduce their risk of getting joint degeneration. And these patients rightly have high expectations. And unfortunately, or fortunately, we tend to don't always meet the aspirations of these patients. So if we look at aspirations, and Sean talked about outcomes, so I'm gonna skim through this a little bit. So in terms of function, if we take doing 10,000 steps a day as an indicator of average or typical daily function, what we find is only 24% of ACL patients in this particular study, compared to 42% of controls, did their 10,000 steps a day. So you nearly half the level of activity in this group. If we look at patient questionnaires such as the IKDC or the Qs, typical scores across a large number of studies were less than 85%. If we take that, a normal score, a typical score of an asymptomatic individual is 95%. We can see large numbers of these patients are performing significantly below what is normal. And the high percentage of these patients report ongoing knee symptoms. Again, this can be anywhere between 25 and 50%, and we'll go into some reasons why in a little while. One of the main reasons why could be the development of osteoarthritis. If we look, the cruciate ligament is by far the biggest driver of any knee injury for getting osteoarthritis down the line. You essentially have about a 50% chance after surgery, whether that's hamstring or bone patella tendon bone, of patellofemoral and tibiofemoral OA 10 years down the line. Your lifetime risk of OA is considerably elevated, and your lifetime risk of a total knee replacement is considerably elevated, regardless of if you have surgery. If we look at return to sport, one of the other aspirations of these individuals, Claire Arden's review came up with around 40% of people return to sport. If you look across the piece, we get somewhere between ridiculous numbers of 30 to 76% of people return to sport. And what you have here is basically the problem with looking at elite versus non-elite people. Sean talked about Frank Noise's rule of thirds. Well, Steph Philby basically came up with it again, and so did England from Scandinavia, where about a third of people get back to sport, a third of people end up at a lower level, and a third of people don't return. The difference between England's and Philby's studies and Frank Noise's were these are ACL reconstructed individuals. If we look at the younger age group, if you want to do well in ACL surgery, treat younger patients, they do better. And so younger patients will tend to go back. But 5 years down the line in these younger patients, they tend to be only half of them playing that same level 1 sport. And again, that is because we lose quite a number early on. If we look at elite sport, and this is mostly European or US based data, even in highly professional, highly paid sports, you still don't get 100% return to the same level. And these people are taking over a year to return to those levels. And when they do return, they are most likely to have a reduced game impact, so their performance isn't as good. And if we look at Champions League based data, again, we've got 60% are at the same level and return to 66%. We're looking at that decreases to about 40% by 5 years, and they have a reoccurring injury rate around 7%. So even in elite, incredibly well-played sport, the outcomes are not great. And one of the biggest problems, obviously, is re-injury. Re-injury is highest in the younger age group, and from some studies can be as high as 30%. And unfortunately, re-injury is considerably higher within our female population. And what we have is also a risk of other knee injuries as well. So we don't appear to have great outcomes from ACL injury and reconstruction, or we're not meeting expectations and beliefs at the very least. So first poll, if you don't mind just completing it, what do you think is going to be most insightful in understanding why people have a poor or a good outcome? Have a click on what you think is the most meaningful one of those in terms of understanding outcome. Give you a second or two. Okay, let's have a look what you all said. So compliance with rehab came up as highest, and then psychology. Oh, you've all been reading the paper. At least a lot of you didn't put time from surgery. So let's see if the literature agrees with that. If we close that down and let's have a look what might predict. Well, one of the greatest factors predicting outcome is garbage in, garbage out, if you don't mind the pun. What you actually take to the theatre in terms of your preoperative status is incredibly predictive of your outcome, whether that's in terms of your level of function, whether that's in terms of your physical scores or your mental scores, whether that's in terms of your preoperative strength. These all are very consistently predictive of outcomes. So we need, prior to surgery, to make sure these patients are at a decent level physically before we actually go on to even proceed to surgery. Quad strength, some of you identified, and again, quad strength either in terms of absolute scores, in terms of 3 Newton meters per kilo of body weight, or in terms of limb symmetry index, are very predictive of either return to activity, return to play, or second injuries. And they're also quite predictive of the way we will run, and the way we move and run at 6 months, as you will see in a future slide, is highly predictive of our likelihood to get things like patellofemoral dysfunction and pain and patellofemoral OA. In terms of the movements, again, we're not always privy to having 3D motion capture labs, so Paterno's study perhaps doesn't rock all your boats. But the second one, you can see this with as a basic video on your phone. If someone has an increase in hip flexion, and what this really means is forward trunk lean or lateral trunk lean, they massively increase their risk of having another ACL injury. So we can pick this up with our phones. If patients are walking with less knee flexion or with less load going through their knee, they are more likely to develop problems further down the line, such as poor functional scores. If they have an altered walking gait, in other words, they aren't walking as quickly, shank velocity, again, they are slower to start running and they are likely to get a poor outcome score. Slower walking speeds, and this is just a basic get up and go test. Slower walking speeds are associated with development of OA, and this is probably via the development of altered biomarkers of cartilage breakdown at the 6-month mark. So again, these people aren't moving normally, and we can actually pick this up with very simple clinical tests. Psychological readiness, you all identified. TSK is the Tampa scale of kinesiophobia. So again, if we score, and the higher the score, the worse your kinesiophobia in this case. So if we have poor kinesiophobia scores, then we are more likely to have asymmetries in our performance scores, and we are less likely to return to activity. And for every point increase in our kinesiophobia, we are less and less likely to return to sport. If we look at the ACL RSI, or the Return to Sport Index from Latrobe, again, what we will see is the scores at 4 months very much predict 12 months. And there are certain fairly overt cutoff scores at somewhere around 1 to 2 years, which are going to be very indicative of our long-term performance. So again, what we have is we have a psychological component. So you also identified incomplete rehabilitation. So again, the literature would support that. So not being able to pass a series of performance tests, and there's more recent literature than this. If we don't fully comply, if we don't completely adhere, then we are less likely to have a good outcome. The more we adhere with the program, almost regardless of what that program is, the better our outcome is likely to be. And it would seem that regardless of the sport people are going back to, greater compliance, so FC is full compliance, MC is moderate compliance, the more likely we are to actually get back to sport. So as you said, the more people turn up and actually participate in rehabilitation and engage, the more likely you are to have a good outcome. Some of you talked about time from surgery. And there is very little evidence at all that graft type, time from surgery, gender will predict the re-injury rate of ACL. And interestingly, I pulled a few of the studies, and I'm going to point out the middle one first, which is from Grindon. Grindon was the study which is cited a lot in saying that for every month you wait after 6 months, following your surgery until 9 months, you get a 51% reduction in injury risk. What I want to point out to you is their sample size. Their sample size was only 100, and their re-injury rate was 28%. Now, 28% is a very high re-injury rate. It's up at the top end of everything reported. And certainly if you remember back to Sean's talks, it's 4 or 5 times higher than what Sean was talking about within his talk. If you look at Don Shelburne's series, which has got far higher number of patients, his re-injury rate is running at about 1%, and he doesn't really care. So you probably need to just look into the detail a little bit, sometimes with the grand statements we get about when you should return. The bigger thing will be not passing your performance tests, not attending. So these outcomes are poor. There's a high probability of getting osteoarthritis a decade later. You have poor function and poor return to sport levels. There's a moderate probability of a second ACL injury. And I put in brackets here, if you return to sport, because if you don't return to sport, you're highly unlikely to rupture your graft. So again, the literature is replete with saying returning to sport causes you to have ACL rupture, or if you pass these functional tests, you're more likely to have an ACL rupture. Well, the problem is the people who pass the test go back to sport, so they are more likely to have an ACL rupture. The people who fail the tests do not go back to sport, so they're highly unlikely to have an ACL rupture because they are not challenging their ACL. So we need to be a little more critical of the literature. Most patients will have this poor outcome because at baseline, they're weaker and have a poor psychological state. They fail to regain quadriceps strength. They do badly in performance tests. They walk slowly. They run, land, and cut, generally with a poor movement pattern. And they show poor psychological readiness to return to sport. If we highlight some things there, the first thing to highlight is weaker and quadriceps. And the second thing to highlight is psychology. So I'm going to spend just a few moments just discussing those 2 points to perhaps give some insight into what you might consider within your rehabilitation. So quadriceps weakness. We know weak quadriceps create problems in the knee. We know weak quadriceps change the way we land. And we know the way we land changes the way we load the joint. And we know ACL reconstructed patients are not only weak in their reconstructed limb, they're also weak in their contralateral limb. So, here's a question. The best way to strengthen your quadriceps is to do open chain exercises. Well, who does open chain exercises? There's only a couple of choices, so let's give you a couple more seconds and then we will go to the results, please. So all the way through rehab, later stage, or no, not never. Majority in later stage. Okay, that's interesting. If we move on. Okay, so why wouldn't we do open chain exercises? Well, there's lots of studies to say that open chain exercises create anterior tibial translation. Except most of those studies were done in ACL deficient knees. If you haven't got an ACL, any pull on the tibia is going to pull your tibia forwards. And the original study, which said closed chain was good and open chain was bad, looked at a bilateral squat compared to a unilateral isometric contraction. So totally different loads. So of course you're going to get different levels of strain because you've got totally different loads. And if we look at strain during a maximum isometric quads contraction, it's significantly less than an anterior draw. And we always get one of these done to make sure the surgery has constrained the tibial movement appropriately, which is a very reasonable thing to do post the surgery. But we don't seem to have any problem regularly checking our anterior draw, but we do have a problem with open chain quadriceps. One is definitely more stressful than the other. And if we look at strain through range, it is unlikely that the strain characteristics are actually very different across range. And if we look at Fitzgerald's work from a long time ago now, the difference is probably not going to be meaningful. And Fitzgerald actually concluded that actually putting some load through the ACL is probably a good thing, and actually trying to stress shield the ACL graft too much is likely to impact on its ability to heal. So if we look at the bottom line here, if we look at anterior tibial translation, well, it occurs mostly somewhere between 15 to 45 degrees, and there is no anterior translation from pull of the quadriceps at angles greater than 60 degrees. If we do engage in open chain exercises in our program, does it make any difference? Well, there's a large number of studies now which show translation is not increased, or laxity is not increased, if we add open chain exercises to our program. And open chain exercises added to our program improve outcome. So at the very least, we probably should consider doing restricted range quadriceps exercises early, i.e. not going into those stress ranges, i.e. maintaining angles of greater than 60 degrees knee flexion straight away, because we can probably strengthen the quadriceps and we definitely won't be loading the ACL graft. So anyway, that's that one. If we look at movement, if you excuse a little bit of biomechanics here. So ACL patients, as we've said already, run, land, and change direction with decreased knee bend and with decreased knee extensor moments. Now, it sounds counterintuitive, but the work we've done looking at this would show that that actually increases the stress on your patellofemoral joint. That could increase your likelihood of getting patellofemoral pain and ongoing knee symptoms and irritation. So we need to improve quadriceps strength in order to get better knee flexion angles, load absorption, and perhaps protect patellofemoral joint. PFC is penultimate foot contact. KAM is knee abduction moments. And what this basically says is that if we have a weak quadricep, so for instance, if our injured leg, our ACL reconstructed leg is our left leg, and we plant that leg and we're looking to cut off our right leg to the left, then if our ACL reconstructed leg is weak, we won't decelerate using that leg on our penultimate foot contact. So we are more likely to put more load into our final foot contact. So for instance, our contralateral or uninjured leg, and so put more load there. So this could be the reason why we get quite a lot of contralateral ACL injuries in people who return to sport. If we haven't adequately rehabilitated their injured leg quadriceps, we are not shielding the other leg from excessive loads. If we look at psychology, and this is probably the final points of tonight's talk, people have a fear of re-injury. But what is the risk of re-rupturing the graft itself? Well, it's somewhere in the region of 6%. In the study from the UK ACL registry, they reported a rate of somewhere in the region of 3%. Now, if we have a fear, and we have a fear avoidance behavior, that's going to create us some problems. And the fear of re-injury in a lot of individuals is the reason for not returning to sporting activity. But actually, our risk of having a contralateral injury is far greater. But we don't talk about protecting the uninjured leg, we talk about protecting the graft. And actually, the whole psychology around you must protect the graft, you can re-rupture, it isn't reflected in the relative risk, but it is reflected in the cost, which is probably the fear of movement and they're then failing to get back to normal functional activities. And the contralateral injury could be related to the fact that these people have injured their ACL, so they've probably got a whole host of non-modifiable risk factors, which are then multiplied by the modifiable risk factors which develop in that contralateral leg, because we are not rehabilitating them appropriately because we have this fear of movement. So what we need to consider is, are we using the right language around these patients? So to conclude, the outcome from ACL reconstruction remains very inconsistent. There is a lot of other stuff going on. We get a lot of comorbidities. There is a lot of other symptoms which frequently limit outcomes. These poor outcomes are linked to preoperative status, quadriceps strength, aberrant movement patterns, and psychological beliefs. We can overcome these. If we prehab them, we make them fit for their surgery. If we strengthen their quadriceps, and we overcome the inhibition and we strengthen early, if we then take the strength into improving their movement patterns and reducing the joint loads and the graft stress by moving appropriately, and if we set clear goals for the patient and we set clear expectations and they understand the process clearly, the risks, the benefits, what they need to do and the attention to detail which is required, we are more likely to have a good outcome. So I'd like to thank you, and again thank the guys from OSSA for use of the platform, and I'll go back to Nick now.
Great, thank you, Lee, for that insightful talk. I particularly like the junk in, junk out analogy in terms of both the physical and some of the psychological elements there. We have had a number of questions through, so thank you to everyone who has posted those, but unfortunately we won't have the time to go over all of them, and I think a lot of them that have come have actually gone on to be answered throughout the talk, so that was great. But one particular one, probably to Mr. O'Brien, would be can ACL injuries be missed on an MRI, and what would you do if the clinical suspicion was there but the MRI did not correlate? How accurate are they at picking them up?
It often, it certainly depends on who reads your MRI. You know, if you've got you're fortunate to have a fellowship trained musculoskeletal radiologist in your department, then the risks of missing it are probably a lot lower than if it's just been reported by a general radiologist. You know, I don't profess to be a radiologist at all, but I look at all my own MRI scans. The one MRI I can sort of read is the knee. And you've just got to get used to what a normal ACL looks like. And also look at the axial views. They're the real important ones, because it nearly always detaches off the femur and you get this gap. It might look great on the sagittal views. There's a little gap where fluid's creating around the top of the ACL where it's detached off the femur. So it can be missed, but a lot of the time it's just that the MRI is not being reported properly, rather than it's truly not there. The other scenario is that one of, is it intact, but you've got functional instability? Then, you know, they're the ones I will speak to the patient, and we'll talk about, well, you know, if it gives way, I'm going to go and arthroscope the knee, and we'll actually look and see what it's like inside. And if I get there and it's definitely gone, I'm going to reconstruct it and go through the consent beforehand. I'm not going to do a diagnostic arthroscopy just to diagnose a potential ACL rupture, and then wake them up and tell them they've ruptured their ACL and bring them back 6 weeks later for a second operation.
Great, thanks for that, Sean. A question now to Lee regarding the emerging literature on the lever sign test, or the Lilly test, and your thoughts on its utility in practice.
I don't know what Sean thinks about this, but the history of ACL injury is fairly clear and fairly predictive. You know, as Sean outlined, about 70% of the cases can be picked up from history alone. Anterior draw and Lachman's are very sensitive and specific tests. I personally don't use any other test because it's pretty confirmatory of an ACL. I don't know what Sean thinks about that.
Yeah, I've heard it discussed at meetings. It's obviously become popularized in the last few years, but I don't think it really adds a great deal to the scenario. You get the diagnosis almost certainly from the history. Then you've got a very strong suspicion that it's an ACL. And if you can relax your patients enough in clinic, you normally get an asymmetric anterior tibial translation on the Lachman test between the two sides. The presence or not of a pivot shift test is sort of confirmatory, but it's often uncomfortable to do in the clinical setting, so I don't always do it. But I don't tend to do the Levy test. To say I've heard about it, read about it, but it's not part of my normal algorithm.
Great, thank you. And just one final question, which is quite topical at the moment in terms of the current restrictions on some of the elective surgical procedures. A lot of the MSK community now are conducting phone appointments, virtual appointments, and people are still injuring their ACLs. During the current lockdown status that we're in, do you see any implications for ACL reconstruction having this enforced delay?
Yeah, literally the week of lockdown, I got a young lad came to see me privately wanting to pay for his own operation because he had a locked knee. And he almost certainly has a meniscal cartilage tear. And they're the ones that I think we're going to be missing, the ones that have got the associated bucket handles, who've got now got a lock knee, and there's no doubt that the long-term results of being able to repair the meniscal cartilage are poorer the longer you leave them for numerous reasons. I agree entirely with what Lee's saying, that basically if your knee never gives way, you do not have to have an anterior cruciate ligament reconstruction, and the results at the end of the day will be very good. In many respects, the best patients are the ones that have the reconstruction, then do nothing afterwards, you know, lead a lovely sedentary life, unlike yourself, Nick, and you know that don't stress anything, not just the graft, but don't stress the whole the whole of the sort of lower limb lever arm. But yeah, I think there'll be a few people out there who would have benefited from early surgery, not because of their ACL rupture, but because of some of the concomitant pathologies that they've got inside the knee.
Great, thank you. That's all we've got time for in terms of questions. So I'd like to thank both Lee and Sean there for their thoughts on that. But I'd just like to kind of bring your attention to the upcoming webinar with Ortho, that some of you may be aware of, and some of you may have seen some of their previous recent seminars. And if you haven't and you've missed those and you want to catch up on them, do have a look at the Ortho Academy on YouTube, where you can see a number of the recent talks on symptoms ranging from rotator cuff tear to hip problems. So this is one to look out for next week if you want a little bit more on ACL, but also some information on OA knee management from Mr. Paul Trigger. So I believe the link will be shared in the chat if you want to register on that particular webinar. And that just leaves us to say thank you again to Lee and Sean for your insightful talk. Thank you to Ortho, our sponsors this evening. And if you've not heard of Northeast MSK Society before, do give us a follow on Facebook, Twitter, and check in with some of the CPD activities that we've got online as well. We will be in touch shortly with all of you with the certificates, the feedback form, and the link to the YouTube video. So once again, thank you to all for watching. Thank you to the speakers and Ortho. Good night. We'll see you soon.